So the recording has started. Let me tell you that if someone has any kind of problem of this recording, please, you are kindly asked to exit the room. So welcome again to the webinar of Neuropsychology and Neurosciences. The webinar will start with Ms. Papaioannou. The title of her presentation is A Case Study of Vascular Dementia, Neuropsychological Assessment and Rehabilitation. Ms. Papaioannou is a PhD candidate here in our college, and we are pretty glad that she's with us today. Georgia, are you ready?
Just a second, please. I'm
yes,
trying
of course.
You can see it right now.
Yes, could you please make it full screen?
It is full screen.
No, by pressing you see the ribbon below? Yes, the first button. Press F5, please.
It is on full screen. It just comes up like that.
Okay, I don't know.
I don't know why, but it is full screen.
Use it as a presented mode.
It still opens like that.
Okay, so you can start.
Okay. So, hello, everybody. I am Georgia Papaioannou. I'm a PhD candidate, as Dr. Klados has already informed you. And today we're going to talk about, I'm going to present to you a case study of a patient of mine which was diagnosed with vascular dementia. So we're going to see from the aspect of the neuropsychological assessment how we've used all this information to reach up until the point where we had to design and apply a rehabilitation plan. To have some information about the patient, she's a female. Her initials are EK. She was 80 years old, right-handed, and she had 6 years of education completed. Now, really important for us to know is that once we have before we begin with the neuropsychological assessment, it's really crucial for us to gather some information about the patient. First information we need to know is about their medical history. So for the medical history of this patient, we have been informed that she had hyperlipidemia, which is actually how we can say that she had high cholesterol. She had hypertension, cardiovascular disease, which actually, because of her heart problems, she had to undergo into heart surgery. Yes?
Georgia, excuse me, we have a problem. Your presentation is not working. Do you have a double screen?
No.
Now it moved somehow. We are on the slide that says medical history. We didn't see the second slide.
Okay, let me start presenting again. Then maybe this will.
Okay. Hi, I'm sorry. I'm working on and off, so I'll just I'll turn my microphone off.
Georgia,
yes,
try to, when you share, not share a window, share the whole screen. Maybe that way we can see the whole view.
Georgia,
The full screen, yes, okay.
Log out and log in again.
To the call?
Yes, please.
Okay, yes, of course. I'll be back.
I'm sorry for this, but these problems may happen in live webinars. Okay, Georgia.
Okay, now, does it roll?
Yes, it seems better. Can you share your PowerPoint?
It doesn't show.
No? Where's your PowerPoint?
It has only my screen and that's not perfect. Yes, I can only share it as the window here. Let me check.
Georgia, please use it. Let me tell you what. No, this
Yes.
is not going to work again. Please close that.
The window, okay.
Yes, please. So share your entire screen as you did before.
Okay. My entire screen, yes.
Fantastic. You cannot see yet your screen. Okay, now something is happening. Fantastic. Go now to your PowerPoint as it was in your computer, right? Fantastic. And put on presenter mode.
Where is it? Where is that?
So this is on the lower, where you see the percentage, the zoom, the next button.
Yes.
The button that is before the minus.
Oh, before the minus. Yes, that's what I was pressing all the time.
Can you please change the slides to see now if they work? Yeah, now they work amazingly. It's fantastic. Thank you.
Okay. Sorry for that. I'm really sorry.
Yeah, no worries, no worries. Please keep on.
Yes, of course. So I was left at the medical history of the patient. So just to have in mind that this patient actually had heart problems. So she had to undergo a heart surgery. While she was having this heart surgery, she suffered from a cardiac arrest. And the next day that she had to go to, under hemodialysis, she suffered another cardiac arrest. After those two procedures were finished, doctors did a CT and find out that she had actually an ischemic cerebrovascular accident, so a stroke, while she was having at the moment she was actually having the heart surgery. So this is the medical history information we have from here. Now we need to gather some information with some interviews we're going to perform regarding her premorbid condition. From her caregiver, which in this situation was her daughter, we have information that she actually, before all of this happened, she did have some cognitive difficulties, such as, for example, she was forgetting things that she was saying, she repeated things, or she kept forgetting when she placed some of her stuff. She was not interested to get involved in any household or any other activities, which actually is a kind of a sign of apathy that really brings out one of the aspects of vascular dementia. She was anxious and overprotective. For her current status, the information we had was that from her relatives, we understood that they've seen she had confusion in her language and she was not really oriented towards time after the stroke. And from the interview we had with the patient, she did understood herself that she had some pre-existing symptoms. And what she kept saying during the neuropsychological assessment over and over again was that she could remember old information, but she had trouble to remember new information. And any additional information we have from the assessment was that we actually saw that she had difficulty to orient herself towards time. She was friendly and cooperative. So once we have all this information, what we need to do is to have in mind to choose the appropriate protocol with the tools that will help us understand better the problems that have arisen from our patient's condition. In this situation, we have a specific tool chosen for a patient her age that has suffered a stroke. It was really important for us to see to have some information about her emotional state. That's why we gave the geriatric depression scale. which has a lot to do with depressive symptomatology that was also found, and her apathy symptomatology that was described from her relatives. To see more information about her language cognitive function, we've given the verbal fluency test. Verbal fluency actually is a test. In the specific case, we've given the semantic fluency part, which has to do with asking the patient to say as many words as they can within 1 minute that belong at first in the category of fruits, the second on category of animals, and the category of objects. So from this specific assessment tool, we have seen that she actually had moderate difficulties in retrieving and producing verbal information from her semantic system. Regarding the attention domain, we've given the digit span forward and backward condition, which was found to be normal. However, the trail-making test, part A and B, revealed severe difficulties in tasks such as this one, which are timed and more complex in attention, that demand visual motor coordination, mental flexibility, and information manipulation. So pretty much has a lot to do with working memory as well, as we can understand. For the visuospatial and visuoconstructional abilities, we have given the copy condition of rheostereoth complex figure test, as we can see on the image below. This test reflected the difficulties this patient had in using efficient copying strategies, so giving us the patient's profile to be disorganized in visuospatial and visuoconstructional perception. And also, from the clock drawing test, as we can see the first two conditions here, the same difficulties were reflected. Clock drawing test, just to have a hint of this, the first one has the free drawn condition has to do with the patient is asked to draw a clock that has all its numbers, and they have to indicate with the hands the hour of 6:45. And on the pre-drawn condition, they have the contour of the clock ready, and they just need to add the numbers and the hands, indicating this time the hour of 5 minutes past 6. And we can see actually what type of difficulties this person has here in this test as well. For the executive functions part, we've continued with the clock drawing test, the examiner's condition, in which conditions we actually give the patient with the contour and the numbers inside the clock, and the only thing they have to do is to actually add the hands to indicate the hour of 10 minutes past 11, 20 minutes past 8, and 3 o'clock. 3 o'clock is the most easiest of these conditions. And on the first two conditions of the examiner's clocks, we have found that in the executive functions, she had severe difficulties in abstract thinking and visual organization. Now, what we exactly mean in abstract thinking in this specific neuropsychological tool, imagine that, for example, at the 20 minutes past 8, the patient indicated the minutes just next to the target hour of the 8, because they have lost the abstract thinking that number 4 actually represents past 20 as well. For the memory part, we have tested the verbal memory with the Greek verbal learning test, which revealed severe difficulties in verbal memory with reduced capacity for new learning. However, we've seen that there is relatively well-preserved encoding, and that we can facilitate the recall once we give the patient cues, which means that in the first, in the beginning of these conditions for the GVLT, the patient was able to remember a lot of information. However, with the longer duration that has lasted throughout the test, in the long delay recall, for example, she was not able to retain all that information as in the beginning. However, when we gave cues for her to recall this verbal information, we could actually see that there were memory traces left of them. And as far as it has to do with visual memory, we've given the rest of the conditions of rheostereoth complex figure test, which actually also revealed severe difficulties in visual memory, of course, with reduced capacity for new learning. So to reach a diagnosis from all of this information we had, according to the medical history we had from our patient, that she had, as we said, hyperlipidemia, hypertension, heart problems in general, a stroke that was revealed from the CT, information we had from her interview about the apathy, about some memory problems, the observations we've made, and the emotional state that we tested, along with all the other neuropsychological assessment we had in her cognitive domains, we were able to actually diagnose this patient as having a vascular dementia. So the next thing that it is really important to do before we actually design the rehabilitation plan is to have some specific goals for our patient. What am I actually aiming at? I cannot aim for the perfect. Okay, I have to sit down and say, okay, for example, for this patient, I want her to be able to manage the deficits she had in focused and sustained attention. But how can this actually reflect to her everyday life? This means that she will have to get better in concentrating in continuous prolonged activities. So for her would mean to watch television or to knit, because she had referred in our conversations that she really liked knitting, but she couldn't focus her attention for too much time into that task. To improve alternative attention and working memory, so to facilitate multitasking, which this immediately has to do in our everyday life with running a household. To confront, of course, any memory issues that has to do with the capacity of information, the duration that she can hold this information, and encoding and storing in long-term memory, either visual or verbal information. And of course, we can also, it is also really good and motivating for the patient if we can to actually address one of their own subjective complaints in this specific situation, since this woman kept complaining about her episodic memory, that she kept forgetting new information, but all of the old information were intact for her. We have used this as a goal as well, so to diminish any incidents of forgetting details of recent events in her daily life. So this rehabilitation program that ran for this patient lasted 52 hours. That was divided into 25 sessions, and each session incorporated attention, visual memory, verbal memory, and episodic memory tasks. Of course, not all together, but gradually introducing them. We will see some of the rehabilitation strategies that we can actually use and give examples from this specific patient. We have retraining strategies which aim to the neuroplasticity of the brain. So we give repeated stimulation in the impaired cognitive function with systematic use of cognitive tasks and exercises. One example that we have here is from the attention process training, and we have a selective attention task. The patient is asked to cancel out as quick as they can the number 3, and after they finish, what we also can add as a strategy that we will see later on, to self-regulate themselves, to self-check themselves, we go and we mark down the correct ones and the error ones together with the patient. So we try to introduce them to self-correcting themselves, to self-correcting. We also have compensatory strategies, either external or internal. The external strategies could be to eliminate any noise. For example, when somebody wants to pay attention to something and to a task they're doing, and any noise on the background is not really helpful. Memory aids, for example, in this specific patient, we have used signs inside her house, specifically one sign on her table, because she always kept forgetting where she was leaving her keys, her glasses, and her wallet. We had a specific place inside her house, on a specific table that she had a sign on it to remember to always put them there so she wouldn't look around for them. And for, of course, visual or verbal cues, which these have been used during the exercises we gave to the patient. For the internal compensatory strategies, we have some strategies such as chunking, so breaking down the information and grouping it together into small segments to help us remember it more easily. Rehearsal, so repeating to retain the information. Form mnemonics with associations, for example, two words that might begin with the same letter. Visual imagery has to do with creating mental representations. And the preview question read state test, PQRST, which has to do with is a strategy to help the patient learn new information. So to give you some examples of protocol-based exercises that have been used on these compensatory internal strategies, here we have an example for attention. This is the protocol of menu. We give the patient, in this situation, we give the patient a restaurant menu with courses and prices next to them, and we give them a worksheet, and we ask them to, for example, to write down the appetizers that contain cheese, which has to do with selective attention, to write down courses that contain seafood and chicken. So they need to manipulate the information, have them both in mind, and each time they find out a course that has seafood or chicken, they need to write it down, and so on. Another protocol-based exercise for what we've said has to do with the PQRST. So for the episodic memory, it was really helpful in this specific part. The procedure is that we give a text to the patient. In this specific exercise, we've given an article about artichokes, a longer one. I just have a small version here. We read it together by taking turns, and then the patient needs to answer some comprehension questions and perform exercises to facilitate their memory throughout the worksheet that they are given. This helps a lot in episodic memory because it helps us preview some information, question which of these are important, read the whole text, and then proceed with retaining, testing themselves whether they have gathered all the important stuff from the new information they were introduced to. We also have instructional techniques such as the errorless learning, which is when we give immediate feedback to a patient to eliminate impulsive errors in recall conditions that can actually lead in future mistakes for the rest of the trials. We have also spaced retrieval strategy. So we expand the time intervals between the trials to be able to facilitate retention of information by setting, of course, specific criteria of success. The criteria of success that we generally use in cognitive rehabilitation are to keep in mind that the patient has 3 to 5 consecutive in 3 to 5 consecutive trials, 80% of success or more. We have vanishing cues, where we provide cues and we gradually diminish within a session. We have the goal management training, which is a framework that we use mostly in executive functions, but in this specific patient was used to be able to address some symptoms that she had of impulsivity and disinhibition. And of course, we can also have some collaborative techniques to introduce the family to some aspects of how they can help in this procedure. For example, we give the patients homework and they need to have it along with a family member that can help them, support them more regarding each type of task they are given as homework. And of course, to have in mind whether our goals are actually succeeded, whether we have progress. They are the ones that give us feedback because they are 24/7 with the patient. Some of these strategies we've just mentioned have been used in visual memory rehabilitation. We have an example here of for the patients for how the patient's procedure went. For example, we start with a complex figure of 12 elements with written instructions, and step by step, the patient needs to observe and follow the instructions to have a copy, as we can see in the first image. Then we can give 2 consecutive learning trials with vanishing cues, so taking away first the drawing and the instructions list then. 1 immediate recall trial without giving any cue, external cue such as the list or the drawing, to promote verbalization of the instructions. 2 short delay recalls with 5 minutes interval. And if we have an 80% accuracy criteria met, of course, in the beginning, that's not something that happens in the first sessions, but while we proceed with that, then we can give 2 long delayed recalls with 15 minutes time interval each. Of course, we have in mind that during all of this procedure, we should have in mind to give the errorless learning cues. So if a patient is not really certain for their answer, they might not remember exactly the instruction, then we need to give them a priori, so beforehand, the answer to be sure that they will not use that error in future. We also have the verbal memory tasks. So, for example, we have 3 categories with 4 objects each that is visually presented to the patient. So we have lists of categorized objects that we give orally with visual representations for 5 learning conditions. Here I have an example of an object from each category that was given for this patient. Then, after the 5 learning conditions, we remove the cues. So we don't have any more, we don't present any more visually or verbally those objects. And we ask them to have 2 short delayed recalls, again with 5 minutes interval each. And if we have an 80% accuracy, then 2 long delayed recalls with 15 minutes interval each. If this does not happen, we should give a 3rd short delayed recall. After we apply, well, actually during the application of the rehabilitation program we have decided to give to our patient, we took into consideration their needs, their abilities, their interests, because many of those protocol exercises can be actually used and adapted for each patient. we need to be sure that we observe a stable improvement of them, and we can do that by having a bit of a quantification on our data. So for example, here for attention, regarding the protocol-based exercises, we've seen that there is a gradual improvement over time. We have given the first protocols that were just to see at which level of difficulty this patient should actually be located on, because we increased the performance with the performance increased along with the difficultiness. So we started from level 1, which is the easiest one, and as you can see, then it is really obvious when we've started to use mixed exercises from level 1 and 2, from TV, menu, music, and again with more level 2 exercises than level 1. On the final one, regarding weather, supermarket, cooking, we have a gradual improvement. For the visual memory, we have the complex figure tasks that were given. We have time and score variables improving as the elements increased, because we started with 12 elements and we went to 14, and we ended up with being able to recall 16 elements. So we can see here the copy, the immediate recall, the short delay, and the long delay recall trials, how they actually had a better score and and they were also quicker in time. For verbal memory, we have the verbal learning lists. We had a success rate of short and long delay recall trials after 3 consecutive successful trials. We changed the difficulty level from 12 words to 16 with visual and category cues, and then we switched back to 12 with only visual cues. And we can see again here the gradual improvement.
Georgia, you have another 4 minutes.
Yes, I'm finishing up actually. No worries.
Okay, thank you. Thank you.
For the episodic memory part, we have the protocol-based exercises, which again show a gradual improvement over time. So the patient was actually really this was really useful for her to retain, to be taught strategies to retain new information that she received. So the conclusion from this monitoring progress was that it was a successful cognitive intervention. We saw gradual improvement because this was within a 3-month period of time. The most complete and exceptional level of performance, so the strongest part of this specific plan, was visual memory. We've had information from her relatives that she presented a really different holistic profile since the beginning of the rehabilitation program. And generally, of course, what we also need to have in mind is that after a 3-month period of applying a rehabilitation program, we need to perform a follow-up assessment. In this case, unfortunately, the patient had some other health issues that did not allow us to perform a follow-up assessment or to actually keep on with the rehabilitation plan. But generally, this is the case. That's why we tend to monitor as well as we go. So this is what I wanted to share with you today. If you have any questions, I'm glad to answer. Thank you for your attention.
Thank you. Thank you very much, Georgia. I have opened the Q&A session for everyone. So far, we don't have any questions. So I think that we can continue to Ms. Evgeniadou, who's going to present us about assessment in epilepsy, neuropsychological assessment in epilepsy. Georgia, could you please close your microphone?
Yes, sorry.
Thank you. Nena, hello Nena. Welcome and thank you very much for joining us today. Can you share your presentation?
Yes, let me know if you can see everything.
Everything is crystal clear, we can see. Thank you very much. We have 20 minutes and some minutes for questions if there are some.
Okay, thank you.
Thank you.
So I'm Nena, I'm a PhD candidate, and I will be presenting assessment of cognitive deficits caused by epilepsy. What we will be seeing is introduction to epilepsy, briefly the risk factors and cognitive impairment, because we have another presentation for epilepsy from a different perspective, and so that we can mainly focus on rehabilitation, creating the neuropsychological profile, assessment, and some examples of test battery that we can use. Before I start, I do want us to focus on a specific question that hopefully can be answered by the end of the presentation. So the question is, if only with the knowledge of neuroimaging and EEG results, type of epilepsy, we have the possibility to understand the nature of impairment in epilepsy, because this is where neuropsychology comes to the picture. So let's begin. Epilepsy is a neurological condition, a chronic disease affecting all ages. It is characterized by an enduring predisposition to generate seizures, unprovoked by any central nervous system insult. So anything that can interrupt the normal connection, let's say, between nerve cells in the brain can cause a seizure. It can be even simple things like high fever to low blood sugar. However, when someone has experienced 2 or more unprovoked seizures, then we can consider that we need to check further if they have epilepsy or not. These are some of the risk factors. We have genetic brain damage from prenatal causes, stroke, brain tumor, severe head injury, but we also have 50% of the cases remaining unknown, having an unknown cause. Now, a patient with epilepsy also have enough social issues, I would say. We can just picture an example of experiencing an episode, a seizure, and how it can provoke fear and anxiety, how that can affect self-esteem, social skills. We know that we have issues with cognitive impairment that can later, let's say, come into the way of any occupational goal that we might have, and can lead to depressive symptoms as well. And there is the possibility of increased risk of psychotic conditions, which we will later see how this can act as a comorbidity in diagnosis. When it comes to cognitive impairments, these are one of the more basic ones, I would say, but keep in mind that the level of impairment or deficit, of course, have to do with the structural cause and the brain areas affected of each patient. So this is the view that we have, a brief, short view of an epilepsy patient. And now we will focus on our part as neuropsychologists, the cognitive rehabilitation part. We have this saying by Wilson, but to put it in a more simple way, cognitive rehabilitation is not just trying to restore cognitive function. It's a complex of activities. We aim to compensate impaired functions by incorporating individual and context-related demands. So we aim to reduce functional impairment and increase as much as we can social activity and quality of life. So the example that we will see today, so that we can be specific in what information we view, is temporal lobe epilepsy. As we know, the hippocampus is within the medial temporal lobe, so we know the importance of it. We know how essential the hippocampus is in memory formation, in consolidation, in retrieval. So we can assume that patients with temporal lobe epilepsy will have such cognitive impairment. So as a first step, we have the lateralization of anatomical lesions so that we can determine the type of deficit. You can see, for example, left temporal lobe abnormalities can cause verbal memory deficit, visuospatial deficits, and you can see the rest of the examples. So the first step is etiology of seizure burden, the brain area, and underlying pathology, and what a critical role they can play in our profession, in us shaping the nature of the neuropsychological assessment, leading us to create a neuropsychological profile of the patient and what we need to take into consideration. Georgia has already mentioned some specific information and profile, clinical profile that we need to have of a patient. So it's a similar case here as well. We need to know the course of a disease. Where did we had any head injury, any surgery? What was the age of seizure onset? What is the brain pathology, cognitive disturbances, any medication, any EEG abnormality? We need to know all of the history background, the profile, the clinical background of the patient, but also any recent change in medication, recent uncontrolled seizure, recent implantation of stereo EEG, because all of that can help us view the level of impairment or the extent of damage, which brings us back to the point to shape an appropriate assessment and see what factors can influence the performance. So we've seen why we need to know this information, because we have neuropsychological phenotypes of individual types of epilepsy and what they can reveal. We need to know the history background, the clinical profile, because we can reveal their pathological underpinnings. We can know the strengths and weaknesses, the impaired and preserved functions, so that we can have future resources to compensate for additional damage. And as previously mentioned, we can check for any type of comorbidity, because that can complicate diagnosis and bias the patient's perception of abilities. So we need to know the lateralization, the brain areas affected, as we have discussed, the history, clinical background, medical background, surgery background, so that we can start building the profile, the reasons that we gather this information, so that we can have the important question of ecological validity, which is from a research setting applied to real life. So the question in our case now is how cognitive impairment can translate into everyday life. What are the consequences of epilepsy, its behavioral and cognitive comorbidities that affect quality of life? This is where neuropsychology and neuropsychological assessment can help indicate such needs and demonstrate possible success. So we now also have why. Why do we need all this information while building the neuropsychological profile? What factors are influencing and what can we get out of it? Now the question is, when can we use neuropsychological assessment? When is it needed? It is quite clear by now that, for example, cognition can already be impaired at epilepsy onset and before treatment. So this calls for baseline evaluation at onset or when diagnosed. In general, as neuropsychologists, we are required to evaluate, as we previously said, reserved capacities, any cognitive or behavioral strengths, so that we can predict any possible cognitive impairment, to not only shape the assessment that we need to perform, but to also check if there is a need for further neuropsychological rehabilitation, maybe after a surgery. So we are there to aid diagnosis, to evaluate cognitive side effects after medication, to see why seizure cannot be controlled, or if seizure is controlled, see if it can cause cognitive problems, and in conjunction with MRI, to assess the suitability of patients for surgery and predict post-operative outcomes. As you can understand, those are a lot, so keep in mind that neuropsychologists have to meet high requirements, because everything that we have discussed and the neuropsychological scores are the results that we will use to reflect the relationship and the relation between risk and benefits of epilepsy course in general, but of epilepsy on an individual level, which is really important. And the last part, I would say, is to see an example of test battery that we will use. There is no case living example, so we will just see some worthwhile tools that have been used. more specifically for temporal lobe epilepsy, since that was the case that we began with. So what we can do is start with a screening tool, either the Montreal Cognitive Assessment that you can see or the mini-mental state examination. With this type of tool, you can start by briefly examine all of these functions so that you can later go more in depth to check strengths and weaknesses of function. So we can then perform the trail making test. This is part A, as you can see here. This is part B. We request for the patient to draw a continuous and in order line from number to number. And in part B, we have letters being added, a continuous line in order, 1A, 2B, and we record the time that they need to complete this. Another tool, another test is the digit span for working memory. As you can see, we have two trials. So we say to the patient that we will say some numbers and they will need to repeat them after us, either in forward or backward conditions. Then we have the California Verbal Learning Test or the Auditory Verbal Learning Test that we can use, again for assessing memory semantic organization. I will briefly explain it so that we can have a view of this one as well. We introduce this list of items to the patient and we have an immediate recall, a later recall, or a delayed after a shorter or a longer period of time. So we have 5 trials to retrieve information from list A, and then we suddenly introduce a different list so that we can also see confusion of what they are able to recall. We have only one immediate recall for list B, and then we go back to list A so that we can see what information they can retrieve, what correct information they can retrieve from items included in the original list. In specific cases, and depending on the patient profile, you can add a Q trial at the end where you separate categories, for example, the category food, so that we can see if the patient can remember that, yes, there was a food, there was a turkey and a sandwich in list A, for example, and see also if there will be confusion with list B. Then, since we've seen that visual memory also plays a role on temporal lobe epilepsy, we can use the ray osteoid complex figure test. This is the original page and shape that we give to the patient to copy. So they see and copy the shape. We immediately take both of the pages and provide a blank one so that we can have an immediate recall from them by memory. And after a short period of time, we request for them to again try and draw what they can remember from the shape. Again here, you can use a Q trial at the end of the test, providing a list of independent shapes so that the patient can identify what were the shapes that were included in this original figure. And finally, we can use the verbal fluency test, where we basically inform the patient that you have a minute to recall as many animals as you can or as many fruit as you can. This is an example of a test battery that you can use in temporal lobe epilepsy. These are some further tests that we can add. The Wessler memory scale assessing different aspects of memory, the Boston naming test, because we have involvement of language areas in temporal lobe, the Stroop test assessing cognitive flexibility, mostly though for dysfunction in the frontal lobe networks, and the Wisconsin card sorting test. So as you can see, there is a plethora of tests that we can use depending on the profile that we've built of that specific patient. However, still, clinical practice across centers reveal a great need for education, homogenization, and standardization of instruments. It's really crucial and important to choose the correct tests. We cannot compensate, for example, by using too many instruments to think that we need to be covered with all of the functions, because we might miss information or accidentally hide information throughout the analysis process. So to conclude, I hope the original question was answered so that we can see how important the contribution of neuropsychology and neuropsychological assessment is in epilepsy and how it can balance risk and benefits. And to keep in mind that neuropsychological assessment is not just building an appropriate profile and selecting and applying the appropriate instruments. It involves a hypothesis, an evidence-driven diagnostic approach to clinical questions, and the most important, something that we've mentioned, from a research setting, trying to do any type of assessment so that we can adapt this to the quality of life of the patient and reduce as much as we can functional impairment. That's it. Thank you.
Thank you very much, Nena. There are a couple of questions from Dr. Ladas. She asks, could you please describe how different seizures can look like? For example, how a person during a seizure looks like and with different seizure phenotypes.
It depends. It can be from numbing of the body. It's not really my background. I do not know many things about epilepsy. It's not my topic, but it can be either numbing or total seizure effect that someone can be on the floor, and that has to do with motor abilities as well, connecting with brain areas, if that makes sense.
Okay, so thank you very much. And another question is, can a single seizure cause damage?
From what I've seen while researching about this, I will say yes. I hope that Christos after me will show this in a better perspective and answer it in a more, let's say, detailed way. But from what I've seen, yes.
Okay, Nena, thank you very much for your contribution, for your presentation. Then we pass the microphone, let's say that if we were in a physical space, to Mr. Christos Steriadis. Christos is a PhD candidate here working on high-frequency oscillations as the early biomarker of epileptogenicity. Christo, can you present your screen?
Yes, of course. Can you see the slides on now?
Yes, of course we can see that. So the stage is yours.
Okay, perfect. So, hello to everyone. Yeah, my name is Christos Steriadis, as Dr. Clara said. I'm also a PhD student. And following on the presentation of my fellow PhD student, good friend Nena, I will drive in a different direction because I come from a different background. The presentation will be a little bit more research-oriented. Again, it will refer to epilepsy, and especially it will refer to high-frequency oscillations, which are some new and very prominent biomarkers of epilepsy, and they can help us a lot during epilepsy diagnosis and epilepsy surgery, more specifically. And I also think that the last question by Dr. Ladas will be answered maybe in the next slide, so bear with me. So, first of all, in order to be able to get everybody on board on what we're going to see next, some basic epilepsy statistics, some basic information about epilepsy. Epilepsy is a complex neurological disorder. It affects approximately 50 million people worldwide, making it the most common neurological disorder. Around 2.4 million people are being affected every year, so you can understand that it is a pretty widespread disorder. Around 75% of the cases start in childhood, and this is in line with a child's brain propensity for seizures. All of us, at some point during our life, could and most possibly will have a seizure. It may not be that important, of course, but just the statistics of it, and linking to the previous question of Dr. Ladas. Also, some of the common symptoms are seizures themselves, which is probably what you have heard when talking about epilepsy. However, we also have some unusual sensations during an epileptic crisis, which mean mainly some sudden change in the taste or smell, or it could be some pinching sensation on the limbs, or both upper and lower limbs, and also we could have loss of awareness. Now, because we talk about seizures when we talk about epilepsy, based on the type of seizures, we can categorize a little bit the epilepsy. So we can talk about focal seizures, which are seizures that start and spread at just one hemisphere of our brain, either the left or the right. We can have generalized seizures, which are spread at both hemispheres of the brain, and we can also have epileptic spasms, which we're not going to go through today because they are, I've called in another sense, infantile spasms. They mainly are related to infants and very, very small, very, very young children. But for focal seizures, which we are going to talk a little bit more today, focal seizures can cause vision abnormalities. They can cause rhythmic, tonic, or clonic motor movements, or they can cause abnormal patient responses to verbal or tactile stimuli. This depends on the area of the brain that is affected. So, for example, you can understand if I have an epilepsy that originates from the occipital lobe, from the back of my head, where the visual cortex and the association cortices are, I could most probably have visual abnormalities. Or when we talk about the precentral gyrus and the primary motor cortex, probably I will have issues related to my motor movements. There are some formal organizations, because epilepsy is very, very widespread, and there is there's a global effort to work in order to cure epilepsy. So you can see, for example, the International League Against Epilepsy is one of the most common global international organizations. Now, let's get into the essence of it. How do we know that epilepsy is out there, but how do we treat it, right? So the first of all, 70% of the patients, luckily enough, can be treated with antiepileptic medication. This means that they take some pills for probably the rest of their lives in a daily basis or a bi-daily basis in order to control for seizures. Those antiepileptic medication either focus on inhibiting the generation of seizures initially, so they stop the generations of seizures themselves. This type of antiepileptic drugs could be valproic acid or carbamazepine. They have different mechanisms of acting, but essentially they try to do the same thing. They have the same goal. Or there are antiepileptic medication that try to restrict seizures from propagating. So, okay, the seizure started, I can stop it from happening, from starting, but I can try to restrict where inside the brain it will propagate and cause more problems and more symptoms. However, this happens for 70% of the patients. For the remaining 30% of the patients, unfortunately, these people suffer from a condition called medically refractory epilepsy. Medically refractory epilepsy, as the name implies, is the type of epilepsy that cannot be treated for some reason, which is not yet known, with antiepileptic medication. The drugs don't work in some people. That's the essence. So for these people, in order to become seizure-free, in order to have a healthy life, the only way to do that is through resective surgery, which is a neurosurgical procedure where a doctor goes and resects the part of the brain, a specific part of the brain for this patient that is responsible for generating the seizure. This area is called the epileptogenic zone. However, in every patient, the epileptogenic zone is not the same. Epilepsy is a very individualistic disorder, meaning that every patient has a different physiological mechanism that generates a different area from where epilepsy is being generated. The most common type of epilepsy is temporal lobe epilepsy, as Nena previously presented, which comes from the temporal lobe. However, it can be from other areas also. So the goal of the clinical community and the research community in medically refractory epilepsy is to find and to very accurately locate the epileptogenic zone inside the brain of its patient. The procedures up until now contain a mix of different non-invasive diagnostic techniques. So a patient goes to the hospital and goes through many different neuroimaging, neuroimaging techniques. They do EEG, they do MEG, electroencephalography and magnetoencephalography. They also do more structural neuroimaging, as we say, so magnetic resonance imaging, MRIs. However, even if we combine the information from all of these neuroimaging techniques, we are still not able to localize with very good accuracy the epileptogenic zone. We have other zones that try to approach it, like, for example, if we see in the MRI an epileptogenic lesion, we can focus ourselves in the area of the epileptogenic lesion as the possible area that causes the epilepsy. We also have the symptomatogenic zone, which is the area of the cortex where we find functional abnormalities. Like, for example, we said I might have epilepsy in my occipital lobe, meaning that I will have some visual abnormalities. So if the doctor, the medical doctor observes visual abnormalities, then they will orient themselves towards the occipital lobe. Up until now, the most, let's say, prominent zone, the most prominent area, the most prominent biomarker, as we say, in epilepsy, for the epileptogenic area, for the epileptogenic zone, is the seizure onset zone, which pretty much is, we take the EEG and we see where the seizure started, because we can visualize the seizures in the EEG. So we say, okay, we see the seizures here, so this should be the area, this is where the seizure started, so this would be the area where, probably is responsible for the epilepsy for this patient. And this is what we need to take out of the brain. However, it's not that simple. Now, thankfully enough, and getting into the main point of the presentation, for the past 10 to 15 years, we have high-frequency oscillations. What high-frequency oscillation is, you see here, for example, that we have a patient, a child, in this schematic representation at the top left, undergoing a regular EEG session. Very easy, very safe. You just apply some electrodes and record the electric activity of the brain. However, in epilepsy, especially in medically refractory epilepsy, the most common neuroimaging technique is the intracranial electroencephalography, which means that it's pretty much the same thing. I want to record the electrical activity of the brain. However, instead of just putting the electrodes on top of the brain, I open some holes and I put electrodes either on top of the brain itself and not on top of the head, on top of the skull, or I put deep probes that go in deeper structures, as you can see with depth electrodes here, and I record more accurately the electrical activity. In both cases, either using EEG or intracranial electroencephalography, my data looks something like this. So they look like the electrical representations of the activity in the brain. If we filter this data and we do a specific type of data pre-processing, we do some filtering and some artifact rejections and stuff like that, we manage to see some distinct events, these distinct events that you see on the right figure, which are called high-frequency oscillations, which are higher in amplitude and have a specific duration, and they stand out from the background. So these events have been found to be very, very good predictors of the area where the epilepsy is. So in the electrodes that I find high-frequency oscillations, it's very, very possible that this area is also responsible for the epilepsy in this patient. So it leads me to this area and makes the clinician want to study this area more. So we talk about high-frequency oscillations, but we didn't give, let's say, definition. High-frequency oscillations are, as you saw previously, oscillations in an electroencephalographic signal between the frequencies of 80 and 500 Hertz, so are very rapid events. They are usually divided into ripples, the lower end, and fast ripples. Ripples can either come from pathological activity, so epileptogenic activity, or can come from physiological activity. So all of us, at some point during our day or during our week, we produce high-frequency oscillations. They are mainly linked to higher brain functions like memory or language, or during sleep. However, fast ripples on the higher end are mainly of pathological origin, so a physiologic brain cannot produce these high-frequency activity. On the figure here, you can see, for example, that in the unfiltered signal, it's not very, very easy to distinguish between the signal and the high-frequency oscillation and the event. But if I filter the signal with a low-band filter at 80 Hz and I focus on the higher frequencies, I can much easier see a distinct event. In any case, this is signal processing, so I'm not going to bore you with that. I just want to say that, okay, not because we just say that high-frequency oscillations are predictors of, the epileptic tissue, but this is what has actually been found. So there are a lot of studies now that support the notion that by resecting the areas where a lot of these high-frequency events exist and occur, we have very good surgical outcome. So what they did is that they said, okay, I take my recording, I see inside the brain, and I see that in a specific area, I have a lot of high-frequency oscillations. If they resect this area, if they take out the brain from that area, the brain tissue from that area, they found that after 6 months, 1 year, 2 years, 3 years, 5 years of the surgery, the patient remained seizure-free, meaning that it became healthy. On the other hand, if we resect an area where, we don't fully include the area where a lot of high-frequency oscillations occur, but partially include them, as you can see on the right here, a lot of channels with high-frequency oscillations remain inside my brain, then the patient did not have a good outcome, meaning that they continue to have recurrent seizures after the surgery. So the surgery failed to cure the patient. So, okay, we're in a very good path. We know that high-frequency oscillations are good predictors of epileptogenicity, so pretty much our job is done. That's not correct, because high-frequency oscillations, despite their great importance, are very, very difficult to be detected. And this is an inherent problem that they have, because they are very, very small events, very fast events. So it's very difficult to find them in the signal. It's not as easy as the previous visualizations. These were purely for visualization purposes. The gold standard up until now is manual detection. This means that a medical doctor needs to take the signal, filter it out, do all the pre-processing steps, and go through the signal and pinpoint one by one the high-frequency oscillations, where they occur, how long do they last, in which electrodes do they occur, etc., etc. It's characteristic that for just 10 minutes of a 10-channel IH data, clinician can take up to 10 hours to detect these events. So imagine what would happen if you had 8 channels, so 8 times this, and not just 10 minutes, but 1 hour of recording. And this is what actually restricts a lot the research around high-frequency oscillations. The fact that it needs a lot of effort in order to detect them. And it's also subjective because, for example, one medical doctor can find 100 of these events in a single channel, and the other doctor can find 110. So they will need to consult together and, get something in common. So it comes with some problems. Of course, as computer science and technology and engineering progresses, we have a lot of automatic detectors, a lot of automatic techniques to do this. So pretty much there are algorithms that you just put your raw signal and you take out the HFO events. That would be ideal. Of course, every machine has its flaws and every algorithm has its flaws. So again, this is not the gold standard because it produces a lot of false detections. It shows high-frequency oscillations in areas that are healthy, and this is very bad for a clinician because we don't want to go and resect and take out an area of the brain that is important and should not be taken out and resected because we are taking out brain tissue, which is important for us. So in general, despite their importance, there are some difficulties there. So, for example, what you can see here, this is what I did, and I'm doing in my PhD thesis. You can see, for example, how a real high-frequency oscillation event is the representation of a real high-frequency oscillation event and the representation of the force detection. They might look similar, but there are ways to, to differentiate between them. So it needs to be very, very, you need to be very, very focused in order to be able to, distinguish between the two. So you understand how difficult this is if you have 1,000 or 10,000 events and you need to distinguish between the two categories. Is it a real age of event or not? So an avenue now in the high-frequency oscillation research is that maybe instead of just going and taking the HFO events themselves, what we can do is work with networks, because we know that our brain is connected, is functionally connected. So there's an ever-increasing number of studies that support that epilepsy is considered to be a network disease. And this came from the idea that there were some studies indicating that two different and very distant areas inside the brain were actually starting to produce seizures at the same time. And this was impossible, theoretically, because it means that we have two areas inside the brain that produce the epilepsy, not just one, because these were not connected physiologically through brain tissue. They were not very proximally, they were very distant, they were not approximately close. Also, a lot of research found that we have areas where the epileptic activity starts. It can start, for example, from my visual cortex on the back of my head and propagate to other areas and create symptoms. So, based on a lot of this research, and very, very recent research actually, because epilepsy networks and network neuroscience in general is a very recent, let's say, recently it has taken a lot of attention from the research community. We decided to also embark on this journey, and we decided to also work with networks and try to bypass this burden of having to detect the HFO events themselves, but at the same time get the same information from the brain. So we want the same information without doing the work. It seems a little bit ideal, but we hope that we can do this. And how we can do this? By creating these networks. So we will take the recordings from the medical doctors. The medical doctors would penetrate the skin, put the electrode on top of the brain, record, and give us the recordings. Then we will construct networks through mathematical procedures, and we will interpret these networks with some mathematical concepts called graph, with a mathematical concept called graph theory, which is an excellent way to study networks practically. And what we will do is that we will go for each electrode and consequently for each area inside the brain and try to assess its importance. Is this area important for the network, for the epileptic network? If it is important for the epileptic network, then maybe by taking out this area, we will be able to disorganize epilepsy and stop it from happening again. It's something like a social network. If you take out a common friend from a big group, maybe people will start dropping their friends together. I don't know. But it's pretty much the same thing. It's taking out the important network, the important electrode, the important area of the brain for this epileptic network. And we will take it a step further after doing that. In order to, nowadays, a lot of machine learning and a lot of artificial intelligence applications are out there. So we will also employ machine learning ourselves. And what we're practically trying to do is that train algorithm based on the data that the medical doctors gives us, and then take a new data set, another data set, not from the ones that the doctor gave us, take a new data set, put it inside our program, and the program would generate and would show us which electrodes are important or not important to be taken out of the brain. So it's pretty much a classifier. In artificial intelligence, it's called classifier and engineering. So yeah, we are trying to do this. So Why is this important? And this is the last slide. I'm not going to bore you with a lot of other signal processing and stuff like that. But why this is important? Because by mathematically analyzing and statistically analyzing signals, we are able to bypass actually the high frequency oscillation event detection, because we know that these events are important, but we don't have the time to go and pinpoint and find each of these events in a signal. So we propose a fully automatic technique, which will be based on functional networks at these high frequencies. And this will be much more subjective because it wouldn't contain the human factor. It aims to restrict the resected area to specific nodes rather than whole areas, because up until now, we take larger areas from the brain. We will try to take very, very specific key points, if I might say, in order to disorganize the network. And also provide a better overall understanding of epilepsy, because, as I said, right now, we move on with the notion that epilepsy is a network disease. So we will be able to better understand what this means by the research that we are trying to do. So if you want to find more information, we have 2 articles that are on that, and they are actually pretty much an initial work on that, which were published very lately. And yeah, I think this is recorded, so you can later on find the links. Thank you very much.
Thank you very much, Christo. One moment, please. Put my headphones. Let me check if there are any questions. Oh, there are some questions. It says here it is not actually a question. Post-surgery. So, Ms. Andriopoulou asks if she's wondering if post-surgery it is common to have functional deficiencies because of the resection, regardless of whether seizure stops, and if perhaps there is some rehabilitation plan.
Okay, to tell you the truth, I'm not quite sure about the rehabilitation plan because it's not pretty much my area. However, in terms of functional deficiencies, that's the big problem. So when you try to localize the epileptogenic zone, what you're actually trying to do, as I said, the epileptogenic zone is a theoretical construct. Its definition is the area that produces the seizures, that generates the seizures, and at the same time, the minimal amount of tissue to be resected, because we need to protect the patient from removing eloquent areas, which are important. So if, for example, the clinician localizes its attention at a specific area, the first thing that they do is that they try to look if that area, if by resecting that area, they would have functional deficiencies. So, for example, Broca's area, or if you have, for example, close to the temporal lobes, you need to be very, very careful about the Broca's area. You need to be very careful about the hippocampus and stuff like that. So they don't proceed to surgery if they find that the area that they finally decided to resect is connected to functional, functional problems. They don't proceed, or they take another area out, leaving that area unattached.
Okay, Christo, thank you very much. Let me answer also this question because I have made a study of this when I was at Aston University. It may be possible. That's why in 2019 we have developed here. If you see, I shared a PDF from a paper that we published in a conference where, based on a huge database, statistical database and imaging database, we were able to map to see if an area is resected, what deficiencies it may cause. So we tried to invent an algorithm, first of all, to detect that, and on the second step, to find the optimal, let's say, resection area, so as not to distort any of the functionalities of the brain. You can read more on the article that I just shared with you in the chat. So, Ms. Argyriadou, what is the time frame in which the individual is considered to be healthy? No need for medication or any kind of intervention.
Yeah, so I think after 1 year of post-surgery, they do after the surgery they do every 6 months or 1 year assessment on reports of the patient or whether they had any seizures or not. But usually after 1 year, they're considered to be seizure-free. After 3 years, actually, is where the gold standard is. But if you don't have, after 1 year, the percentage of having another seizure drops significantly.
Okay, thank you very much. And another question from Dr. Ivanov is this method suitable only for corticography, or it could be applied to EEG data?
Yeah. So up until now, the high-frequency oscillations are very difficult to be detected in EEG, in scalp EEG. They can be detected in scalp EEG now with high-density EEG and stuff like that, and very controlled environments. But our research, at least, is focused on intracranial recordings because it's much easier to find this type of events. The next step is to be applied, this pipeline to be applied in EEG data, because it's pretty much the same pipeline. You just need to account for some artifacts and some issues that come with EEG and not with intracranial electroencephalography.
Fantastic. Also, let me complete, Christo, here that mainly this started from the MEG community. We can very easily detect high-frequency oscillations with MEG because due to the spectral content of the high-frequency oscillations, their amplitude is very, very low. This amplitude can be detected from magnetometers because it's not reduced due to scalp resistance and so on. With EEG, it's a bit more difficult. That's why they need to be closer, let's say, to the upper layers of the cortex. However, as Christo said, using the high-density EEG machines, we are now in a better position to localize them using the high-frequency EEGs. Thank you very much, Christo. And the next, it's me. So let me present you my screen. I will present you this screen. And now, actually, I chose to speak about neurofeedback because, just a second. Okay, can you see my screen? Yes, you can see that. Okay, fantastic. I chose to speak about neurofeedback because I will see the questions afterwards. Because neurofeedback, as you will see afterwards, it was invented by NASA and by mistake, let's say, accidentally, and they tried to treat some seizures that were caused from, let's say, from a chemical, from the fuel of the rockets back then. Anyway, before going into that, let's start with QEEG neurofeedback. And the first thing that we need to discuss about this in order to introduce you better on this is about neuroplasticity. Thanks God we have neuroplasticity because I cannot imagine how a non-plastic brain how would look like, or how we would look like. We wouldn't learn, we wouldn't have experiences, we couldn't, let's say, we will be a very constant thing. Starting about neuroplasticity, I would like you to see here this image. Let me make pointer options. I would like you to see these images, where here we have a, let's say, fetus of 25 days, and here it goes, you see, on 100 days, this yellow thing, which is the brain, actually become with a very, very small dot, and in the first 100 days, it's grown so much as the head and so on. And this is up here, it's the 8 months before the birth, the kid before the birth, and here it's the 9 months. As you can see, in 1 month, the brain has, let's say, developed mostly the sulcus and the, let's say, the gyri, the sulci and the gyri. And this, let's say, sulci and gyri are there because imagine that the brain has been enlarged mainly, but in a very confined space, which is the scalp. Okay, so it makes this, let's say, how to say that, wrinkles or so in order to fit its surface inside a very confined space. On a neural level, on a cellular level, here we can see how a neuroblast develops to a full, let's say, length neuron. Here we have the neuroblast where the axons are, let's say, prolonged. Here we have the soma, the terminals, and the axons, and then we have here, for example, we have this could be a pyramidal neuron, and this is a complete, let's say, full-scale neuron. Here, as you can see, is in a very small scale, let's say that, the neuroaxons developed in, here it's newborn, here it's in the 1 month, 3 months, 6 months, 15 and 24. And as you can see, the neurons grows bigger and bigger and bigger. They form more dense grids because of the neurosynapses, and these neurosynapses happen because of the experiences that the kid has on the first, let's say, ages of his or her life. And you see that after 2 years, we have a very dense network of connections that is responsible so as to understand our environment, but also to react to our environment properly. So, what is neuroplasticity? Let's give a definition. Actually, neuroplasticity is the ability of our nervous system to make changes in anatomical, chemical, psychological, or functional properties. Here, what we can see is that the primate fetal brain contains mainly 30 to 60% more axons than the adult brain, and axons actually is the gray matter of, let's say, of the brain. During the gestation, there are widespread changes in types, so as the location of the cells and their interconnections. Also, we have cell migration at birth, which changes, which produce changes in local cortical connectivity, and we have, let's say, some simple exposure to particular stimuli like images and so on, where learning is not required, that determines the brain organization during this critical age of infancy. Here I saw a figure where we see how the different pathways increase during the growing of an infant, a kid, of a toddler. We can see that in the first, let's say, months of his or her life, we have everything, of course, increases rapidly, but the first thing that increases a lot is the sensory pathways, it's vision, hearing, and so on, and this is because they are needed in order to understand the environment, to interact with the environment, and so on. Then, after 7, 8, or 10 months, let's say that language goes on its peak in order to start the communication with the parents and communicate the needs and so on. And later on, at around 2 and 3 years old, we have the peak of higher cognitive functions where the kid starts to learn and combine things from the stimuli that it gets from the sensory pathways and so on. Following that, I would like to show you what's happening in the brain using the Metzgerich example from the, let's say, early 80s. Here, what Metzgerich did was he had an old monkey where he mapped in this picture. Here we have the somatosensory cortex, let's say that. And here is the hand representation. And the hand representation, it's if we zoom, it's like this. Metzenich showed that here it's the mapping of the different fingers of the first, second, third, fourth, and fifth. Then Metzenich take this old monkey, let's say that, and he cut it his third finger. And after 2 months, we see that the area of the brain that was represented for the third finger was, let's say, is lost. And this place was taken mainly by the close fingers, the 2 and the 4th one. That's why when we have seen that when we don't have, let's say, a sense, for example, when we close our eyes, then we can hear better. Or if we would like to concentrate, we close a bit the music. Now, another example, it was 10 years later almost, by Pascual Leon on 1993. What he did actually, it's that he mapped the motor cortex for representation of reading fingers in braille readers, and which are controlled bilaterally. And what actually he found is that the cortical representation of reading figures were significantly enlarged at the expense of representation of other fingers in braille's readers only. While they can even observe changes within a day when they practice, for example, for 4 to 6 hours. And these studies, these findings were replicated with piano players and other learning experiments. Let me check if everything is okay. I don't see a message, so you hear me properly, so let me continue. So here are the main mechanisms underlying neuroplasticity. The first one is that the change in balance of excitation inhibition, which happens very, very quickly. And if inhibition is removed, the regions of functional influence could be increased. Then we have the second and third actually is what we know from the behavioral, let's say, practice, where we can strengthen existing synapses through long-term potentiation. This is actually what we say if you, how to say that, reward one activity. Actually, what you do is you increase the chances to see this activity again, to repeat its activity. And on, let's say, on a contralateral way, when we punish behavior, what we actually do is we decrease the probabilities of this behavior to be repeated. And this is what we say in, let's say, neuroplastic level, that we waken the synapses through long-term depression. So we depress the synapses in order to make them more weak. Also, we have changes in neuronal membrane excitability, so as to send faster or slower, let's say that, to be activated and set pulses. On the other hand, on the fifth, let's say, level, we have anatomical changing. For example, we have new axonal terminals and formation of new synapses. Of course, this takes longer. Traditionally, let's say, it's not considered as a feasible mechanism of plasticity, because you need to spend a lot of months for using such kind of plasticity. Also, here we should say that the mechanisms are not mutually exclusive. Okay, while plastic changes can occur on multiple time scales and according to multiple rule-based systems, so it's not something so straightforward. Okay, said that a bit theoretical for neuroplasticity, let's go to quantitative EEG. Let me tell you that EEG stands for the electroencephalogram. Christos spoke about IEG, which was intracranial electroencephalogram. Here we are going to see about the quantitative electroencephalogram or quantitative EEG. So what is quantitative EEG? Quantitative QEEG actually is something very, very specific. It's an EEG recorded from 19 electrodes, and it's actually a method of quantifying EEG with a very precise and reproducible way in order this to be able to be replicated. Okay, and the actual use of EEG is that the QEEG is that we use that in order to make to quantify changes on a single, let's say, patient. That if this person is, let's say, close to the general population mean, or higher than the general population mean, or lower than the general population mean, let's say that. And actually, how we do that is that we make a QEEG to a patient with a certain symptomatology, and then we check in which areas and which brain waves this person is higher or has higher or lower activity compared to the general population. And we connect that so as to develop proper neurofeedback protocols. As I told you, the QEEG is recorded from 90 electrodes only, that it's, let's say, placed on the scalp using the 1020 international system. And actually, you can see here some QEEG signals. Here you can see the 1020 international system, and actually how you do that is you take the nation point here. Actually, you measure from the nation to the union with a tape the distance, let's say that. And then you take the 10% of the distance is the frontoparietal region. Then after 20% is the frontal region, after 20% the central region, and so on. And the same happens on the lateral, let's say, side. So now the normal distribution plays a crucial role in the QEEG because, how to explain that easily? Every feature in nature, it follows the normal distribution. Here I put a big asterisk because, let me rephrase, every random, let's say, variable or random feature in nature follows a normal distribution. And how we can observe that? The central limit theorem of the mathematics says that if you have a variable, like, for example, the height of people, if you take 10 random people and measure their height, you may not watch and observe the normal distribution. However, if you take 1,000 people, you see that their height distribution will be closer to normal. If you take 1 million people, then their height distribution will be even closer to normal, and so on. So everything depends on the size of the sample we have in order to define the distribution. And what's good about the normal distribution? In the normal distribution, we know very easily where a score lies. For example, if we measure the alpha brainwave activity on the prefrontal cortex, and we see that this has a value of 5, let's say that, and we know the mean and the standard deviation of the alpha prefrontal activity, and let's say that this is true with standard deviation of 1, then we can easily understand that a 5 is very high compared to the normal mean. In this sense, what we actually know is that in a general, let's say, sense, that the 68% of the observation belong to -1 +1 standard deviation. The 95% of the observations belong to -2 until +2 standard deviation. And the 99% of the values belong to 0.58%, let's say 3 standard deviations, -3 until +3 standard deviation. So imagine if you take a value of, let's say, alpha prefrontal, left prefrontal cortex, that it's somewhere here, then you understand that this person has greater alpha activity on the prefrontal cortex compared to the 99% of the total population. So something is wrong. And actually here, it's how the QEEG looks like. For example, here we have the delta absolute power, and here we have some colorings. the colors is how close this is to the median. Okay, here let me tell you that this normative, let's say, databases, because it's actually normative databases, they build by recruiting many 1,000, 2,000, 3,000 normal participants, not participants without any kind of disorder. And based on their recordings, we make these norms actually. Okay, it's how we make the norms in the typical psychometric tools. And considering this, what we can note here is that this person there, it's his or her left temporal and centrotemporal, frontotemporal, let's say, activity of the delta gamma is a bit increased, is very close to 3 standard deviations. And here we notice that the central, actually the left central activity of the alpha brain is very, very high. And this is probably linked, I don't know, with a disorder. What we actually target with neurofeedback is such extremes where we try to normalize, so in this case to reduce them, in order to make them closer to the average of the normal distribution. And if you like to connect that with disorders, let's check this profile. This profile from a depressive person, where we see very increased, let's say, activity of the prefrontal alpha activity. And here we see the same, we see another person of the same of the alpha brain wave activity and so on, without depression. As you can see, the red area here sets over 2 standard deviation from the norm, which is actually statistically significant. Let's see some other QEEG findings. On mid-90s, the Chabot and Serfontaine reporting that children with ADHD had an increased theta primarily in the frontal regions and the frontal midline. 2 years later, Clark and his colleague make a study, the first actual study of EEG difference between children with different DSM-5 types, DSM-4 types, compared to ADHD combined type with 2 inattentive type and 20 inattentive type and 20 control subjects. And they had increased theta and reductions in alpha and beta brain waves. In a follow-up study, the same group 3 years later found increased theta but also decreased beta in combined type and decreased alpha in the inattentive type. And I spoke mainly about ADHD because ADHD is the flagship of neurofeedback. It is considered, let's say, better than the medication because there is study, I don't present the findings here, but there is study that they compare neurofeedback with current stimulants that they give to children suffering from ADHD. Neurofeedback has much better results, so that's why the American Association of Pediatrists have it as a level 1 of let's say, of therapy for ADHD. Here are some other parameters that are mainly linked with the communication between different brain regions, and this is mainly based on coherence metrics, which actually coherence is imagined the correlation in the frequency domain. So we see here that we have not so much significant, let's say, connectivity in low brain waves, and we have in, let's say, middle to high brain waves in beta and high beta and so on. So let's make an introduction to neurofeedback. The first slide, of course, it's, let's say, the slide dedicated to Barry Sterman and his colleague that accidentally, let's say, found neurofeedback. And actually the story was that back then, when they went to the, let's say, to the space, the rockets use a fuel that's called monomethylhydrazine, and this is caused this caused seizures in the crew of the spacecraft. And actually, they also, back then, they sent some animals to the space so as to see how they perform, how is this their physiology during low gravity, in a low gravity environment, let's say. However, on the same, let's say, time, Barry Sterman made an experiment with some cats about neurofeedback. And actually, one cat was by mistaken went to the spacecraft that has been on the SMR training group. SMR training group is a protocol of neurofeedback. And when they come back, they notice that only the cat didn't have any seizure. And then they find out what happened. And this was the first study, actually, that they did regarding neurofeedback. And here you can see a figure from back then that all the people, both the control and the SMR conditioned people, have similar, let's say, latency of onset in minutes in vomit, vocalize, pant, salivate, but in seizure, you see that it was very, very, very delayed in people that had SMR condition. And from this, research around neurofeedback started, and actually this was one of the, let's say, primary studies about neurofeedback was in epilepsy. That's why I spoke after Christos has introduced HFOs for epilepsy. And actually what we tried to do in a project back then in 2019 is to try to online, let's say, record the high frequency oscillations so as to use them in a neurofeedback setting so as to, let's say, suppress them and to see what would happen. Anyway, so actually, what is neurofeedback? Neurofeedback is the direct training of brain functions in order to normalize its performance. In neurofeedback, actually, we reward the brain for changing its own activity to a more appropriate patterns, and this is based actually in neuroplasticity and in the rewarding system. Okay. And how we can check, of course, if a brain is normal or not, based on our previous findings and based, let's say, on QEEG. Here, if I could make a critical, let's say, conversation, critical discussion about this, we have two questions arise. First of all, can we change that? Yes, we have seen that we can change that. That so far so good. But the main question that arises here is, this change that we make in the brain is followed by a behavioral change or by a change in the condition that in a disorder that we would like to treat. Or this, in some cases, yes, in some cases, no, we don't know yet. That's why it's an open field for research. So how a neurofeedback system looks like here, as you can see, for example, we have the kid or a patient or whatever. Let me here make a parenthesis. Neurofeedback is not only applied on patients. We apply neurofeedback a lot in a normal population, in non-pathological population. And we, for example, neurofeedback is used a lot by athletes for peak performance, from corporate members, and so on. How neurofeedback is performed. Here we have the person that does neurofeedback. We record his or her raw EEG signals that is, let's say, goes to the therapist computer, where the therapist puts some thresholds, okay, where it tells you that we need your alpha to be higher than this level, or your alpha should be lower than this level, or your theta, your beta, and so on. And all this is depicted in a real time on the subject. Okay, so the subject actually has how to say that realizes online how their brain waves look like and how they are increasing or decreasing. So actually, in a way, he or she tries to modulate them and regulate them. Because I see that we don't have so many minutes, I will close with conditions how neurofeedback can be used. It can be used in anxiety and mood disorders, in ADHD, in addiction and sleep. But actually, at the end, we have, let's say, the example of depression. Here, as we saw before, here is the template of a person who is suffering from depression. We see that we have increased alpha activity in the frontal, left frontal sides. Actually, the prefrontal, this is explained by the theory of emotions, the model of prefrontal alpha symmetry. It's completely understandable. And here you can see how, after neurofeedback, how this head looks like. How we do that in order to decrease, here neurofeedback can be used in order to decrease the amplitude of alpha waves in the left prefrontal cortex and equalize it with the right prefrontal cortex. So we don't want just to reduce them, we just want to equalize the both hemispheres bilaterally. So that's all actually. Thank you very, very, very much. And let me check if there are any questions. Let me stop sharing my screen. Okay. Q&A. So can neuroplasticity in early brain development explain infant amnesia? I don't know if this has to do with neuroplasticity, but mainly it's due to neurodevelopment. Probably we have amnesia. Actually, I don't know if you mean the condition, the disorder, or the normal amnesia that the children have. If you mean the normal one, it's not amnesia, it's just low memory, let's say that. Let's phrase it correctly. Then, yes, so to neuroplasticity is about the development. Are these either publicly available like normal data from PhD? Yes, there are, but they are not available. There are normative databases actually that someone needs to pay. I believe that's around 5,000 or 10,000 euros or something like that, in order to get access and make analysis. So since I don't see another question, let me pass the microphone to Aristea. Aristea, are you with us?
Hi, yes, I'm here.
Okay, thank you. The stage is yours.
Thank you, Manos. Thank you. Hi, everyone. Very happy to be given another opportunity to talk about my all-time favorite topic about consciousness and focusing on the neural correlates of consciousness, actually. Let me share my screen with you. Very slowly, though I will.
Aristea, your bandwidth is not so good. Would you like to close your camera?
Yeah, sure. Can you see that?
Yes, we can see that. Can you make in the present mode?
Yep.
Fantastic.
Okay. Great. So, quick question before we begin. Are you conscious right now? Hopefully you respond yes to that. How do you know that you're conscious? A typical reply would be, because I know. And that's true. We know because of metacognitive abilities. Do we experience during the day, could we possibly experience different states of consciousness? Well, the answer is yes. During the day, during 24 hours, actually, of course, we experience that very different states of consciousness of being awake and alert versus falling asleep. But also during sleep, we experience different conscious experiences. During the different sleep stages, during dreaming, the main dream stage would be the REM stage, as you well know. But what about during the day? Could we then also experience different states of consciousness? And again, the answer is yes. Mind wandering, for example, is quite different qualitatively when you scan the brain than being fully alert. So, and then again, of course, we have the pathological conditions of coma patients with different levels of coma, so different stages of consciousness, most probably there as well. And then we have patients, people under anesthesia, who have been investigated a lot with regards to the neural correlates of consciousness, people under hallucinogens, which change the state of consciousness, a very, very interesting field of study, to my opinion. And all these combined to understand where does consciousness lie. For every one of you who has been through a lecture who has attended a lecture about cognitive functions, you will know that certain places of the parts of the brain are responsible for certain cognitive functions. But that's not that true about consciousness. And this is where the thing gets complex and extremely interesting. First of all, let me introduce you to our research team, which involves my dear colleague and friend Christos Franzidis from Lincoln University, two alumni of ours, Triandafylos Gravalas and Christina Katsoridou, Tom Stoneham from the philosophy department of York University, and Dan Dennis from the Department of Psychology at York University. So far, we have published some things, we submit proposals, works in progress, as you see, and all that was initially motivated from research in consciousness during sleep, and collaborating, philosophers and neuroscientists collaborating to probably suggest a new theory of consciousness. Let's see where we're at regarding the neural correlates of consciousness, or which are the brain networks or parts that produce that experience of consciousness. Now, that's the first thing that complex the situation. It's not a function. It's rather an experience. It's a state, what consciousness is. It's not like executive attention, which is prefrontally mainly. It's not like working memory. It's not unlike all the other cognitive functions. Typically, we study the neuroscientific methods to study consciousness are with EEG, with functional MRI, and MEG is used lately. What is investigated, let's focus on EEG, for example. What is investigated is actually oscillatory activity, especially the A band, which seems very important about consciousness. When we say oscillatory activity, we mean the synchronized activation of neurons, which brings about that signal that you saw in Manos's presentation. Now, consciousness is believed to arise from the integration of neural activity from regions receiving sensory information, because, as also Aristotle supported actually, when we are awake, we receive sensory information all the time. Either we do perceive that we perceive them or not. So we cannot have consciousness if we do not have sensory integration of information, that is. And it's the integration of information which is important, that brings about that sense of being conscious, because it's not information per se. When you study stimuli, isolated stimuli, like only visual stimuli, only auditory stimuli, you can see reactions from a human participant also when they are unconscious, during sleep, for example. So it's in the integration, not only the perception, but integration of sensory information that brings about this experience. Now, regarding the conscious perception of stimuli, functional connectivity during a resting state, EEG, so with eyes open while at rest, the functional connectivity in the default mode network, and also in the somatosensory and frontoparietal regions, seem to be the ones who are mostly responsible for conscious perception of stimuli, as opposed to unconscious perception of stimuli. Also, function and collectivity of whole brain networks during sleep have shown, and especially during REM sleep, have shown the similar brain networks responsible for consciousness, for the experience of consciousness. Now, it is what we should pay attention to is that it is the integration of information and the sense of flow that come from the synchronization of EEG oscillations. So these highlighted words play an enormous importance in defining and investigating consciousness. First of all, we have reached a point where we know that it is something about the integration of all that information, not only bottom-up information, so stimuli coming from outside and being processed, but also top-down information, memories, learning schemas that at the same time influence your perception of the stimuli and are combined to guide that integration. The synchronization of EEG oscillations shows that integration of information out of which that sense of flow comes about, where actually when you see the cognitive definitions of consciousness, one of them says that consciousness is what connects the past, the present, and the future all at the same time. So right now that we're discussing, actually, that hopefully you're paying attention to this presentation, you are not only paying attention to the present, you might also be thinking about your future goals, or maybe I want to ask that question. And how am I going to ask that question? Well, because I thought of information that I have from the past. At the same time, you know who you are, obviously. You know that you have two hands. You know that you're a human being. You haven't forgotten about that while paying attention here. And how do you know that? From your previous experiences, from the feedback that you've gotten from everyone during your life, from other people who seem very similar to you, actually, and from previous knowledge. So you see how during each and every moment that we're awake, past, present, and future are all combined and integrated in that conscious perception of stimuli and provides us with that sense of flow. Now, that sense of flow, of course, which is peculiar, is much more intense during intense dreaming. That flow where sometimes it's uncontrollable, like when you dream like you're walking towards somewhere, and that somewhere is bad and you shouldn't go there, but you also can't avoid it. Sense of uncontrollable flow, because consciousness is pretty different qualitatively while we dream. But not all that different, because it shares similarities with awakened consciousness. Nevertheless, we said that there is top-down and bottom-up integration of information at the same time. For the top-down integration of information, it seems that cortical and thalamocortical circuits are responsible, whereas for the bottom-up integration, circuits for arousal states such as the diencephalon and the brainstem, which are involved, of course, in the circadian rhythm of a human, are crucial for that kind of integration. The synthesis of those pathways explains seemingly diverse effects of anesthesia on consciousness. So, for example, from studies on effects of anesthetic-induced unconsciousness, it seems that it is mainly these pathways that seem to be the ones to produce the experience of consciousness while you're awake, as opposed to while you're under anesthesia. Is there any specificity, though, of those neural networks? One of the most prevalent theories of consciousness is the information integration theory, and another one is the global neuronal workspace hypothesis theory, both of which have done wonderful and amazing efforts to produce testable hypotheses about the neural correlates of consciousness. Let me go through them pretty fast. The global workspace hypothesis suggests that we have several networks in our brain which function as parallel processors and are connected to that so-called global workspace when they exchange information with each other, as you see here. So when each one functions in isolation, if it can function ever in isolation, you don't have consciousness. When there is a synergy between them, you have that sense of flow and integration. A main criticism of the global workspace hypothesis is that consciousness has both a subjective and an objective aspect, and this theory can produce testable hypotheses only about its objective aspect. But as Aristotle supported, consciousness is an intrinsic capacity of the humans, so integral to the part, an integral part of the body, so we should be able to measure it holistically, not only its objective aspect. Information integration theory makes an amazing effort to also assess the qualitative subjective aspect of consciousness. And in some, they have suggested a certain value, which is called phi, through which you measure the ability for integration at any given moment for a specific brain. And that phi, so that ability for integration, not necessarily the integration itself, but the ability for integration represents a brain's consciousness levels. Interestingly, though, phi is not equal to the information involved in it, but it is above and beyond that. It is calculated mathematically, and a basic critique, although one of the most prominent theories of the neural correlates of consciousness with much evidence to support it, is that from one of its developers, it is almost impossible to calculate phi for a human brain which is so highly complex. So still we remain at the problem of assessing the subjectivity of consciousness. So you can see main differences between them, that the information integration theory supports that it's a posterior so-called hot zone parietotemporo-occipital networks that are responsible for producing the sense of consciousness, whereas the global network supports a frontoparietal and sensory areas responsible for that. The information integration says that it tries to assess both its subjective and objective aspects, whereas the global network hypothesis can assess only its objective aspect. And then we go on to suggest that maybe apart from oscillatory activity, we could assess the brain's aperiodic activity while being awake and while falling asleep and during sleep, which may provide us with that subjective information that is still missing from those theories. Now, we know that consciousness is much more complex than just its constituents. It also involves that subjective phenomenal aspect apart from the objective one, as also Aristotle supported. It resembles a radar signal, where the end signal is a combination of all signals from previous radar sources, plus their noise, plus something more, which is their noise in the case of signals. We suggest to explicitly assess the aperiodic components of brain signal. That aperiodic component is scale-free and asynchronous, as opposed to oscillatory activity. And for years, traditionally, it is being filtered out of the signal that we assess because it is considered more or less, grossly speaking, a part of brain noise with no useful information, actually. So aperiodic activity consists of many different frequencies used by the brain to functionally communicate with each other. Why isn't it simple noise? Because there is it has a dynamic nature, or from its non-linear activity. And remember that almost everything in nature is actually non-linear. For example, aperiodic activity is observed in several natural phenomena such as earthquakes, forest fires, biological networks, traffic, and many, many more. It is believed to carry useful information regardless of the underlying power law principles. So we know that aperiodic activity transmits very useful information for other cases, for natural phenomena. Why not for the brain? Why not for consciousness? Also, narrowband oscillations that are responsible for the synergy of different brain areas between them to have an end result of consciousness are limited in transmitting long-range signals, whereas distant neuronal hubs firing at the same time could dynamically produce aperiodic activity. So, measuring a periodic activity provides us with the ability to assess distant networks, and it is distant network comparison that is described by the global neuronal workspace hypothesis that brings about consciousness. So it seems that a periodic activity is a great fit about assessing, in combination to oscillatory activity, to assess a consciousness in a holistic way. Also, nothing also because we're running out of time. Nevertheless, there are some very limited previous studies on a periodic activity in different consciousness states, and they show that indeed a periodic activity differs between different sleep stages, and that it could be, and we suggest that we must assess both oscillations and a periodic activity, which can also be called brain's avalanches, the brain's individual fingerprint, for a complete account of consciousness. Maybe it is a periodic activity after all that reflects that qualitative excess that phi represents in the information integration theory. Other neuroscientists suggest that it is maybe consciousness that does not actually emerge with sudden onsets, as the global network hypothesis suggests, but it is there all along, and it depends on where you focus your attention, whether you will experience conscious alert wakefulness or dreaming or deep sleep, etc. So what kind of activity is ongoing in the brain? Well, a periodic activity, actually, as opposed to oscillatory activity. So this also suggests that it could be a periodic activity could involve valuable insights into the studies of the neural correlates and functionings of consciousness. This is our suggestion of our method we could to use to analyze sleep EEG data, combining oscillatory and a periodic activity. Will not go through them into detail though right now. And we also suggest that maybe multi-organ, like brain-heart-muscle interactions, along with brain activity and sleep biomarkers, could provide us with a more, combined with high-density EEG, could provide us with a more integrated view of consciousness, because the brain does not work in a vacuum. The brain is an integral part of a body, and several other organs are involved in there and attached to it regarding their functionality. So maybe we should expand our investigations to other organ interactions as well. This is just a figure of the method that we are suggesting with multi-organ interaction, high-density EEG, staging of sleep, and integration of that information with machine learning techniques. And what about theory? Well, as we said, the global networks hypothesis suggests that investigates, actually, describes consciousness from an objective perspective, and the other theory, the information integration, tries to operationalize a subjective one, but it is impossible to calculate phi. And overall, both of them neglect the third quality of consciousness, long described by Aristotle and recently discussed by Stoneham, and that would be the relationship between the observer and the perceived object, which changes dramatically depending on the perceiver's state of consciousness. So we do believe that a periodic activity can provide us with valuable information about the neural correlates of consciousness to add upon the existing theories of the NCCs. Thank you very much for your attention. Hopefully that was not very boring for you. It is very exciting though for me. And let's see if we have any questions. But first I need to unshare my screen.
Thank you very much, Aristea. I don't see any questions on the Q&A. However, the presentation was really fascinating, and you know very well that I'm also fascinated about the models, not only for consciousness, the mathematical models, but
yes, I know,
generally for how the brain works. And there is a lot of distance, let's say, that we need to cover as scientists and researchers between, you know, the experimental models and what we see in the experimental practice. With the pre-developed or the refined models about brain, let's say brain functionality, I would say that. And lately I was studying about how tech systems and the brain and how, let's say, the dissipative structures are formed outside the, let's say, the, excuse me, the non-equilibrium, which is something that are very highly, let's say, connected with consciousness and everything and all of that.
Yes, it's not a surprise. It's
And
not
you
a
know that
surprise.
I think that Anil said, I don't remember if he was that he said one of the best, let's say, scientists in consciousness said that we cannot understand consciousness if we don't understand quantum physics.
I would agree completely. I believe I can see from my very poor knowledge on that, I can clearly see patterns. If someone explains it to me in a simple manner, I can clearly see patterns between that and the neuroscientific investigation of consciousness, the phenomenon of consciousness, actually. And it is also the philosophical accounts of consciousness that
Exactly.
have helped me a lot to understand as far as I can the phenomenon of consciousness. That's why I believe that there should be an integration of scientific disciplines to completely understand consciousness. We can no longer stay in our shells and require to understand such a complex and amazing phenomenon by ourselves. We have to collaborate. We have to help out each other. And hopefully we are on the way to do that with the collaborations that we right now have developed.
Nice. So Evangelos Marco asks if there is any input feedback papers, for example, from psychotherapists and or psychotherapeutic schools organization regarding consciousness. Thank you very much. He says it's impressive presentation.
Thank you, Vangelis. I'm not aware of specific papers, but I'm pretty sure that in each psychotherapeutic approach, in their philosophy, because they all share a specific philosophy, they do, if not explicitly, they would implicitly suggest some things about consciousness.
Okay. Thank you very much, Aristea.
Thank you for the invitation.
We thank you for your presentation. And now let's close with our last, let's say, presentation from Dr. Megari.
There is another question, but we don't have the time, do we?
No, there's not another question. Just a second to check.
Yes, there is. Let me show you. From Nikolaos Sapkaris.
Nicolas Sapkaris. Yes, I'm really sorry. How effective does fMRI capture the dynamic and distributed neural processing underlying consciousness, considering its limitation in temporal resolution and potential confounds such as vascular reactivity? And how can these changes be addressed to advance our understanding of neural correlates?
Well, that's a wonderful question, isn't it? As you very well put it, Nicola, it is in the fMRI has its limitations regarding that, the temporal limitations. That's why high density EEG is traditionally used, not only because it's cheaper, but also because it is more useful to see changes from second to second in the brain. Nevertheless, fMRI can provide us with valuable information and also about the structural changes that the brain undergoes during different states of consciousness. And it is MEG actually lately that draws the attention of everyone. And thankfully we do have MEG at York University as well, because MEG shares less, we could say, less limitations, and it can provide us, as it seems, with valuable information about investigating consciousness. No single method has yet, a single method to do that is yet to be found, though. Thank you.
Thank you very much, Aristea. So let's continue to the next presentation from Dr. Megari, who is going to talk to us about the neuropsychological functioning of patients with brain tumor. Dr. Megari, can you hear us? Hello,
Yes.
nice to meet you.
Yes.
So the stage is yours. Thank you very much for accepting our invitation.
Thank you. I'm glad to be here with you today, and congratulations to all the presenters. So I will share my screen now. Give me some seconds. Can you see my presentation?
Nope.
Okay, I will try once more. Okay, now I suppose that you will be able to see it.
Something is going on.
Something is happening.
Yes, exactly. If you can put it in a presenter mode,
Now?
we don't see any change.
Because I am on presentation mode, that's why.
No, I see your mouse. Can you go lower in the zoom area and the icon before the minus, the minus icon?
Just a moment. Because I see full screen, that's why I don't know what's happening. Let me try once more. How about now?
Yes, again, we can see that, but listen to me, please. We see also the slides on the left side. If you go on the lower ribbon where it says 58%, yeah, okay, you see the minus.
Yes, I see.
Okay, the previous icon, this one, press it, please.
Now?
Nothing. Do you share the, just a second, Calliope, can you share your entire screen and not the presentation?
No, I don't share my entire screen. I shared only the presentation.
That's why it is this. If you share your entire screen, you press this button that I told you, then it will be full screen.
I need to share a window or the entire screen?
It's better the entire screen.
The entire screen. Okay, I will do it. Entire screen. I set my entire screen. And now what?
Now, we don't
Do you
see
see
it.
my presentation?
Yes, can you press now the button that I told you?
Yes, I did this.
Okay, now it's perfect.
Okay, I'm glad. So, after this trouble, I will present to you my presentation about neuropsychological functioning of patients with brain tumors. I'm Dr. Calliope Megari, Academic Director of a postgraduate program of clinical psychology and clinical research supervisor. I'm a postdoctoral researcher at Lab of Cognitive Neuroscience, School of Psychology at Aristotle University of Thessaloniki in Greece. I'm the head of the Center of Creative Activities of Children with Disabilities, Municipality of Kalamaria in Thessaloniki, Greece. I'm the leader of rehabilitation of COVID-19 patients working group of NeuroCovid International Neuropsychological Society. I'm editor-in-chief of Journal of Psychiatry and Mental Health. I'm a general secretary of board of directors and ethics committee president of Hellenic Neuropsychological Society, and we have the approval for this webinar. And I am a member of Public Interest Advisory Committee, Diversity Committee member of American Psychological Association. Now, about brain tumors. Brain tumor is rare, but has one of the lowest survival rates of all cancers. Tumors of the central nervous systems are classified according to the cells or tissue in which the tumor grows, as well as the grade of malignancy. Malignant brain tumors, grade 3 and 4, are cancerous, grow rapidly and are associated with poorer prognosis for survival, while low-grade gliomas, grade 1 and 2, are histologically benign but may recur or progress, particularly if complete removal is not feasible. Other tumors, for example, meningiomas, rarely recur but can seriously affect neurological and neuropsychological functioning. The site of tumor growth is typically related to neuropsychological deficits. For example, if the tumors are located at the left hemisphere, commonly the language is affected. However, due to compression and displacement effects, more widespread damage and global neuropsychological impairment can occur. Now, the symptoms that the patients experience. A variety of symptoms can be found and also presenting, most common being headache with or without raised intracranial pressure and seizures. Albeit seizures are less common in patients with high-grade gliomas versus patients with low-grade gliomas. Patients may present with stroke-like symptoms and involving hemiparesis or have mental status or neurobehavioral changes, which are fairly common. And another common symptom can be a psychopathology symptom. The following is a list of common psychiatric symptoms that can be experienced by those diagnosed with a brain tumor. For example, they may have confusion, lack of orientation, adjust coping difficulties. They cannot cope regarding their emotions. They have sadness, they have worries, their behaviors that arise in response to stressors. They may experience delirium, a sudden change in mental status, including the confusion or delusion, a belief that contradicts reality. Depression, a group of symptoms that includes sadness and loss of interest in pleasurable activities. Paranoia, psychosis, they may have delusions or hallucinations. Social withdrawal, less involvement in social activities. Suicidal behavior, which is something very important for us to assess and to conduct a risk assessment about suicidal behavior, can include a number of behaviors, including talking about wanting to die and gestures toward harming oneself. And violent behaviors, physical, sexual, or emotional attacks. And now, the severity and nature of neuropsychological impairment is a key factor influencing quality of life in people with brain tumor. Quality of life is a very important aspect when we are talking about patients with cancer, and when we are talking about brain tumors, is a very important aspect, their quality of life. Obtain accurate information about a person's neuropsychological status is central to planning their rehabilitation and supportive care, and moreover, neuropsychological functioning has been found to be related to prognosis and tumor recurrence, and may be more sensitive in predicting early tumor recurrence than imaging techniques. Accordingly, research in the brain tumor field has focused on the nature of neuropsychological impairment, the relationships between neuropsychological status, the tumor type, the location of the tumor, the size of the tumor, and the impact of impairments on everyday functioning. Everyday functioning is a very important aspect for clinical psychologists to take into account, and assessment of everyday functioning must be conducted. And there is a considerable variability in the rates of neuropsychological impairment reported in the studies. For example, rates of neuropsychological impairment have been found to vary from 12.5% to 91%. A key reason for such variability appears to be the different methods for assessing and interpreting performance on neuropsychological tests. Three broad approaches to analyze or classifying impairment are evident across studies. The test-specific analysis classifies impairment on the basis of an individual test. For example, we have a particular memory test. The domain-specific analysis that determines impairment based on the composite of test scores that relate to a particular neuropsychological domain. For example, we have tests for attention and processing speed, and the global index of neuropsychological impairment that involves calculating and composite across different domains of cognitive ability, for example, summing and averaging standardized scores across tests of several cognitive domains. Patients with brain tumors can develop impairments in multiple cognitive domains before or after surgery that can have a profound effect on function and quality of life. The type of impairment can be influenced by tumor morphology, extent of resection, and post-surgical treatment, tumor recurrence, the age, and the concurrent psychological distress. However, in any given case, it's difficult to make precise predictions about cognitive outcome due to individual differences and long-ranging effects of diffuse brain tumors on networks throughout the brain. Assessment of cognitive function is therefore vital in informing management and in monitoring the long-term effects of tumors and interventions. And this approach has great strengths, but also important limitations. In-depth assessment of an individual can take several hours, in addition to scoring and report writing time. A long assessment may be highly sensitive in the general population, but be overly influenced by fatigue, pain, or other factors in clinical groups, and especially when we have patients with cancer. And there is such a wide range of specialized tests available that there may be little overlap between those used in one center and another, making comparison of outcomes complex. Many tests have strong or unknown practice effects, limiting their use for repeated assessment. That's why it's very important to use tests that are need for repeated measurements, and they don't have the learning effect. That's why we use, in these cases, we use alternative forms of the test in order not to have the learning effect. Now, another type of assessment that we use is the computerized cognitive assessment that gives advantages, including highly standardized administration, the capacity to measure reaction times with millisecond precision, and instant scoring reporting. In this way, indications of possible impairment in language, memory, orientation, attention, numerical cognition, spatial bias, and ability to imitate gestures can be delivered in around 10 minutes, helping to inform management in settings where patients may be intolerant for longer assessments, when we have stroke, when we have comorbidity, when we have other conditions along with brain tumors. And the advent of the touchscreen tablet added portability and suitability for bedside use, greater hygiene, a more intuitive means of interaction, and further reduced cost. And there is a program that is that's commonly used in the US. It's called OCS Bridge. Is developed a tablet app that is hybrid between very brief screening and more in-depth assessment. And in patients with brain tumors, usually we start from a question, then we have neuropsychological testing. We have to decide which test we should use. And it's very important to assess the emotions and specific cognitions if the tumor is localized. And we have a diagnosis of cognitive deficits and description of emotional status. And all this can be used in our recommendations for our patients. And these are some commonly used neuropsychological tests. They are standardized and in the Greek population, and they assess a broad range of cognitive functions, ways, Western memory scale, California Verbal Learning Test, Ray Auditory Verbal Learning Test, Ray Complex Figure Test, Rail Making, Symbol Digits, Troop Test, Verbal Fluency, Wisconsin Car Sorting, the Clock Drawing Test, the Token Test, and the Boston Naming Test. There are some commonly used instruments. And now some research between neuropsychological functioning between patients with brain tumors and healthy controls. Research shows that participants with brain tumors perform significantly poorer overall on tests of neuropsychological functioning than matched controls, and their performance was significantly impaired on the executive function and memory domains, but not on the attention and processing speed domain. And research also reports higher level of impairment on tests of executive function and memory as compared to other domains. Due to the tumor and its treatment, many patients suffer from cognitive deficits during the course of their disease, mainly in the domains of attention, processing speed, memory, and executive functions. But research has shown that there are controversial findings on tests of attention and processing speed. Some researchers say that these domains are intact. Some other researchers say that these domains are impaired. Aside from different tumor characteristics, a likely reason for the inconsistent findings between studies relates to the selection of tests to assess neuropsychological functioning. And this reflects a broader issue in the neuropsychological literature, whereby researchers commonly employed different tests to assess the same abilities, thus making comparisons between studies difficult. And now we present the second stage regarding people with brain tumors. This stage is cognitive rehabilitation. Cognitive rehabilitation is a part of their treatment, and this is very important to know the issues about rehabilitation therapy that is based on the principles of neuroplasticity of the brain. It is a type of rehabilitation that offers exercises aimed at improving various domains of cognition, such as attention, memory, language, and executive and control functions. And the expected result is an indirect positive impact on functional deficits affecting everyday life. And proper treatment with these therapies can help enhance the social and professional integration of patients, may help these patients work individually and independently at some domains regarding their social life, their occupational life, and their regarding their recreational activities. And just to say a few words about cognitive rehabilitation programs, two main types of exercises are used for this treatment: the compensation and the retraining. In retraining, we retrain brain functions with regularly repeated exercises specific for the deficient aspect of a cognitive function, and this is referred to as restoring the deficient function. Another rehabilitation technique is to work with the preserved cognitive functions by compensation techniques. In this case, the patient will be encouraged to develop alternative means to achieve their goals. And new strategies can include the use of planners, checklists, or memory notebooks. And these two forms of training work together. Restorative processes help to develop compensatory strategies and vice versa. And the final goal is to increase functionality of the patients. And advances in cancer treatment have improved survival rates, and the number of studies on survival has thus increased. These studies have been focusing more on aspects such as cognitive decline and quality of life. Neuropsychological screenings are vital after a brain tumor diagnosis, and these assessments help patients and healthcare providers to understand how the tumors affect their brain functioning and their overall health. And conducted periodically, these assessments track changes in brain behavior relationships, and help in forming a prognosis. Cognitive deficits in patients with primary brain tumors are usually milder and more diffuse from those secondary to stroke. Cognitive problems can have substantial impact on patients' life, particularly as many patients are affected by this diagnosis at a relatively young age when they are often active in their work, family, and social life. As patients live longer with possible cognitive problems due to improved treatments, prevention, and treatment of these problems among patients with a brain tumor are very important. And of course, we don't forget that neuropsychologists play a very important role when we're talking about patients with brain tumors. And clinical psychologists, of course, play a very important role, because we said earlier that brain tumors are accompanied by psychopathology symptoms. So it's very important to work as a team along with the medical professionals, the medical doctors, the nurses, the family of the patients, and other specialists who are involved regarding the treatment of patients with brain tumors. Thank you for your attention.
Thank you very much, Dr. Megari. Let me put my headset. We have some questions as I see right now. One moment. So, can you hear me?
Mm-hmm. Yeah.
It says brain tumor is far from the limbic system. Can it still cause emotion regulation abnormalities?
It causes. We consider that it causes emotional dysregulation and other abnormalities regarding psychopathology symptoms.
Yeah.
Mm-hmm.
Okay. Okay, let me check if there is another question. One moment. No, there is not another question. So, thank you very much, Dr. Gary.
Thank you.
I will, let's say, share my screen to tell you a couple of things about our master, and just a second. Give me one moment. Share my screen, entire screen. So can you see my screen? Yes, you can see my screen.
Yes.
So, Robbie,
We can't hear you very well, I think.
give me one moment. Can you hear me now better?
Yes, much better.
Yes.
Okay, fantastic. So, this was done, let's say, on the framework of the Master in Clinical Neuropsychology and Master of Cognitive Neuropsychology. And actually, I'm very, very, very proud and glad because 4 out of the 3 presenters, Dr. Ladas, Mr. Steriadis, Ms. Papaioannou, and Ms. Evgeniadou, were actually part of this master, others in clinical neuropsychology and others in cognitive neuropsychology. And I would like very briefly to introduce you both masters. The first one is about clinical neuropsychology and focuses more, let's say, on understanding of behavioral and cognitive deficits that follows brain damage in clinical population, such as individuals with neurodegenerative disorders, different type of dementia or multiple sclerosis, epilepsy, tumor, stroke, TBI, and so on, as well as with children with neurodevelopmental conditions. The second, which is a Master of Science in Cognitive Neuropsychology, covers again the same topics, But the difference is that the first one, it's more clinically oriented, and there is, let's say, a practicum on, let's say, on a clinical setting, on a hospital, and so on. While the second one is most let's say, research oriented, which provides the students with theoretical background as well as with advanced research skill that help the student to pursue further a research career or a PhD, let's say, in the fast developing fields of neuropsychology and or neuroscience. And I'm very happy to say that both masters, let's say that. I got a message. So is everything okay? It's raised hand. Okay, one of please. Both masters include modules that are, let's say, hands-on modules around neuroscience, and let's say, personally leading a module that we get inside the lab, and we have a sense, let's say, of neurofeedback. And while on the second semester, I'm doing the applied neuroscience lab, when where students learn from an idea that they have on an experiment. They develop the protocol, they run experiments, EEG experiments, they record EEG signals, and we get up to the point that we clean the EEG signals, and then they go for further analysis and so on. By the sense that I wanted that our students, at least to be able to can stand in a research lab worldwide, an EEG research lab, in a very good, let's say, shape, and can work and be confident about making EEG experiments and providing at least to PIs and to the research professionals with clean EEG signals. Of course, if you would like to have more information, you can send me an email on my professional email, and I'm very happy to, let's say, respond to you. Christina, so I have a raised hand here. Would you like to ask something? Just a second to check how, if I can open it. Just a second, just give me one moment, please. Give me one moment. Okay, you can write any question to the chat, or you can also open your microphone. Christina Bogdanovic, can you hear me? You can open your microphone. You raise your hand. Okay. So, are there any questions? Hi.
Hi, it's great to attend this presentation. This was unfortunately by mistake. I'm sorry to interrupt you.
No worries, no worries.
I will just continue following the presentation, and if I have any questions, I will let you know.
Thank you very much.
Thanks.
So thank you everyone who joined us today. I hope that at least we inspired you to search further about neuropsychology and neuroscience, and we inspire you to look more into the brain and what's possible to do. We hope to see you in another, let's say, event that we have probably in the future, let's say that. Thank you very much for your attendance.
Thank you, Manos. Thanks, everyone. Bye-bye.
Thank you. Have a good